Good evening. Welcome to ICD Section 15 webinar. Today, we is the last speaker of this May, and we are very fortunate to have with us Professor Dr. Sunil Mudaya. Before Dr. Sunil start his talk, let me introduce Prof. Sunil. Dr. Sunil Mudaya completed his Bachelor of Dental Surgery and Master in Specialty in Orthodontics and Dental Facial Orthopedics from Mangalore University, India. He did his schooling at Lawrence School, Lovedale, Nilgiris at Ramakrishna and Mysore. And he is presently the Professor and Chair, Department of Orthodontics and the Dental Facial Orthopedics, Cook Institute of Dental Science. Among his achievements is he is the founder of the NGO Anuraj, a social initiative to support societies vulnerable in education and health. He founded the Cook Institute of Dental Science in 1999. He has signed an MOU between various institutes, namely University of Hong Kong, UITM, Mahidol, University of Geneva, Surumi University of Japan, Mostopo from Indonesia, Mahasaraswati from Denpasar, Indonesia, University of Indonesia, National Yangming University, Taiwan, University of Periodontal, Sri Lanka, and also a university, Dr. Bob Lee, something, Studio from Hungary, and Orthodontic Society, and also School of Odontology, Hanoi Medical University in Vietnam. He also has MOU with University of Alabama, Birmingham, Botswana, and also Segi University, and the last one is Slovak Medical University. He's the founder of Samadan, a private clinic facility for the aesthetics, cosmetology, and also specialist dental care in 2022. He's the founder of the president of Avishkar Research Lab. In 2014, he founded a research laboratory which presently doing the cutting edge research in the field of medicine. He's also the founder president of International Dental Education Association, IDEA. His position is in India country representative for the Southeast Asia for dental education. He's also the country representative for the India Association of Dental Education at IDEA, and he's represent India International Collaboration of Mekong River, IDCMR. His research interest, he's also been instrumental in the starting of pioneering research in the field of medicine and dentistry, and a few of these which are in advanced stages. So tonight, Professor Sunil Mudaya will share with us a very interesting topic, concept of artificial intelligence, functional and fixed appliance in orthodontics, the treatment perspective. And our webinar tonight is also broadcast on live YouTube, which I will give the link later on for those who want to join on YouTube. So, Professor Sunil Mudaya, the screen is yours to share with our participants tonight.
Thank you, Prof. Thank you for the kind introduction.
You ready to go, Prof. Sunil?
Just a minute, Prof.
Oh, okay.
Good evening to all of you. I wish to thank Professor Mohammed Ibrahim, Secretary Education of the International Council of Dentists, Section 15. Thank you very much, sir, for inviting me today to speak.
My pleasure, Professor.
Well, participants who are listening to me today, good evening to all of you from the southwest part of the Indian subcontinent. We are located in the tiny province of Coorg on the southwest mountains of India. This is a picture of our institute from in the clouds.
Sorry, have you shared the screen? We can't see your screen. We can hear you, but not your screen. So, Professor Neil, we cannot see your screen.
Now,
okay, that's better.
Can you see? Can you see it now?
Yeah. Go ahead. Can see now.
Sorry for the little glitch. So this is where we are located. This is a cafe on the institute where I am the founding dean. That's the Indian subcontinent, and that's the red area is where we are located. It's otherwise called the Scotland of India. We've got temperatures running from around 18 to 26 degrees through the year. And we produce in most of India's coffee and pepper and spices. This is a view of the institute I serve. Now, the title, as you all know, is the concepts of artificial intelligence, functional and fixed appliances in orthodontics, a treatment perspective. I will be speaking to you about a brief about removable appliances, then fixed functional appliances, fixed appliances like lingual, insignia, and tip edge, a small note on sleep apnea devices, and aligners. So I'll also show you cases that we've actually done in our clinics. So most of the presentation is going to be that. So here we go with the removable orthodontic appliances. Treatment with removable appliances will not provide the best answer to every orthodontic problem, as you know. A small degree of the irregularities are impossible to treat with removable appliances, and some very severe malocclusions respond very well, as said by, well said by Philip Adams. So, removable orthodontics can be devices that can be removed from the mouth and can be inserted into and removed from the oral cavity by the patient at will. So there are two kinds: appliances which are clasped to the teeth and are referred to as fixed plates. And as you know, removable appliances, which are those that lie loosely in the mouth and produce their effect by modifying the pattern of activity of the orofacial musculature, and hence pressures produced on the teeth by these activities. And these are called functional appliances, basically muscular and musculoskeletal devices. So these are the components that we have. You all know we have retentive component, an active component, and a base plate. Indications of a functional appliance are growth modification, limited tooth movement like tipping, arch expansion, and of course, retention after comprehensive treatment. Major tooth movements can be done with removable appliances. Now a note on functional appliances. These are those that change the posture of the mandible, holding it open or open and forward. There is passive tooth bond, like an activator, a bionator, herbs, and a twin block. There are also active tooth bond, like modifications of an activator and a bionator. Tissue bond appliances, of course, like Frankel appliance. So now here you see some functional appliances. You see a bionator, an activator, a Frankel on the right corner. Now let us have a small discussion on the class 2 malocclusion case where a functional appliance is used in a retrognatic manner. This is the lateral pterygoid muscle. Now this lateral pterygoid muscle needs to be stretched with a functional appliance to bring this retrognatic mandible forward. Now when the lateral pterygoid muscle is brought forward, is stretched forward by this functional appliance, the growth centers are activated and there is more growth in the growth centers, that is in the condylar area over here, in the angle of the mandible, and here in the symphysis area. Along with this, there is also bone deposition right along the lower part of the mandible and from the condyle up to the angle of the mandible up to the symphysis. However, along with this, you will find there is, let's go with another color, resorption of bone loss in this area, that is in the coronoid process and in the so this is very clear. How we do this is we make a functional, we construct a functional appliance where you position the mandible in a forward position so as to bring a class 2 retrognatic mandible to the correct position. You're bringing it to the correct position by positioning the mandible forward. So when you place this functional appliance, the lateral pterygoid muscle is stretched, which creates a movement in this area and causes deposition of bone right along the areas where you see the plus points, and there is resorption in the negative points. So I think that video was self-explanatory on the actual orthopedics of a functional appliance. Now we have twin blocks, activators, bionators, and Frankel, which are the mainstream of removable functional appliances. So now we go with, let's see a few patients that we've done at our clinics. Here is a 12-year-old male patient who reported with a chief complaint of backwardly positioned lower jaw. It's very clear. You can see it in the pre-treatment photograph. On examination, we found that he had a retrognathic mandible and an orthognathic maxilla with 8 millimeters of lip incompetency. The growth pattern was found to be average. He had an overjet of about 9 millimeters with an increased deep bite, as you see, and a very easily observable lip trap. We decided to start the case with twin block for correcting the retrognathic mandible. Twin block was found to be the ideal choice as the maxilla was orthognathic with an average growth pattern and the VTO was positive. This was treatment following the twin block insertion. These are pictures. Twin block was used for approximately 8 months of an active phase and followed by 2 months of a supportive phase and then 6 months of a retentive phase with the appliance. Now, you can very easily observe how the lip trap has been reduced, the overjet has been reduced. Now see these photographs. The pre and post-treatment comparison shows a very straight profile post-treatment due to advancement of the mandible. Lip trap has been clearly corrected. Please check for the improved smile. He is confident now. Average growth pattern was maintained here. Please observe the intraoral pre and post incisors. Check for the change in the molar relation from class 2 to class 1 molar. There's a decrease in overjet by about 8 millimeters here. Lower incisor proclination was avoided by incisal capping. There's no change in the alignment of arches, as was seen as no expansion appliance was used here. Here's another case. Reported 11-year-old child reported with a chief complaint of a backwardly placed jaw. On examination, we found a retrognathic mandible was seen with lip trap. There was an increased overjet and a clear convex profile, which can be seen here in the pre-treatment photograph. This is following placement of the twin block. Total treatment time here was 15 months with change in molar relation from class 2 to class 1 with reduction in overjet. Observe the molars. There's no change in the alignment of arches as no expansion appliance was used, just like the case that presented before this. Now let's go on to fixed functional appliances. So this was just a bird's eye view of the treatment we do with removable functional appliances. Now here we go with fixed functional appliances. As you all know, forces, power scope, herbs, advanced sync 2. These are a few examples of fixed functional appliance. There's a video showing the working of a fixed functional appliance. Herbs appliance is a customized device. The device is followed by fixed appliance treatment to align the teeth. This is after the herbs appliance treatment. we complete the treatment with a fixed appliance to align the teeth. Now I'll show you a video showing the working of a fixed functional appliance called forces. You must be aware of forces. Fixed appliance treatment here too is completed and followed by forces appliance. Here it's the opposite. With the forces appliance, it's the opposite of Herbst, where we do pre-treatment fixed appliance treatment, and then post a fixed appliance treatment, we use the forces. Exciting to see the way treatment happens with forces and Herbst. It's literally like a piece of art. So now let me show you a case report of forces. I just wanted to show you a video to make you all understand how the forces works. Here we have a 17-year-old patient who reported with the chief complaint of smaller lower jaw and spacing between the lips. He reported at our clinics. He had a clear retrognathic mandible with retroclined upper incisors and a convex profile with mandible locking of the mandible. These are pre-treatment extraoral. Since the retroclined upper incisors were locking the mandible and not allowing it to grow, it was getting trapped. We decided to start the case with leveling and aligning of the upper and the lower incisors, thereby, increasing the overjet. Here you see upper incisors were proclined and crowding was corrected with a fair amount of aligning of the lowers. Forces fixed appliance was then placed after reaching 19 into 25 SS to advance the mandible using the remaining growth that we still had, favorable growth. Implants, however, were placed in the lower arch and engaged to post in the lower anteriors to prevent proclination of the lower incisors. Following 10 months of fixed appliance therapy, observe the pictures. Now observe the pre and the post. Post-treatment change is seen with profile becoming straight, very clear because of mandibular advancement. Lip incompetency has been reduced and there's no change in the nasolabial angle here. Now let me show you one more case report which reported at our clinics with the power scope device. This was a 16-year-old patient who reported with a chief complaint of small lower jaw, spacing between lips. He had a retrognathic mandible with proclined upper and lower incisors and a clear convex profile. Observe the class 2 molar relation on both sides. We did initial leveling and aligning with the 014 night eye. This was done basically to increase the overjet. Observe the alignment. Power scope fixed functional appliance was used to advance the mandible bilaterally by around 5 millimeters. Advance the mandible. Power scope used for 10 months observe the post-treatment pictures which showed improved profile and lip competency. Well, the pandemic has shown us the importance now of removable appliances, wherein they require fewer appointments to the dental clinic. I think it woke all of us up because patients couldn't report at clinics, patients couldn't report at hospitals. Teledentistry came into the picture, which for many years we tried encouraging people. It never happened. So I think teledentistry and removable appliances made a big jump in the past 2 years. So this is our teledentistry center. So we have a lot of patients coming in with, a lot of queries, a lot of problems, a lot of questions, and then they need a lot of answers. So our teledentistry department became very strong during the pandemic. Now let's go on to clear aligners. This seems to be one of the futures of dentistry. Everybody wants aesthetics. Everybody wants things not to be seen anymore, but yet getting their treatment done and their teeth aligned. So it's a very personalized treatment plan, as the slide shows you. Once you finish your consultation and your doctor has examined your teeth. So the steps are: you start with the consultation, your doctor examines your teeth, then you get a personalized treatment plan through a digital scan. There is no too much of, impression materials and things. And then you have aligners are customized for you. Here are the intraoral scanning, different commercially available scanners in the market. Here you have, this is what happens as different steps of aligner process. In the clinician's office, there's an initial consultation, records are taken, impressions are done, treatment planning forms are done. Then it's shipped to Align Technology, that's to the laboratories. The impression is scanned, treatment software process, ClinCheck. The ClinCheck set up via internet to the clinician's office. So it's all via internet or teledentistry. Here, impressions are scanned. Treatment software is processed at Align Technology, and ClinCheck will be sent by the aligner company. So here the impression is scanned, the treatment software is processed and sent to the aligner company. Here it's shipped back to the clinician's office. And as you see the lower portion here, where you see all the aligners kept, that's at different stages of treatment. It's quite patient friendly. Advantages of intraoral scanning over impressions: there's accuracy, there's comfort, you get a high resolution interactive image of your teeth, there's precision, and there's progress assessment. Here we have a 26-year-old female who reported with spacing in upper and lower anteriors with lip incompetency. This is one of our aligner cases. She was very nervous and, sort of very unhappy. She didn't know how to manage, and she was working too. Just to share something more private here, she happens to be my niece. Intraoral examination revealed a class 1 molar relation with decreased overbite and trauma from occlusion. It's very clear. You can see the trauma from occlusion. Yeah? There's normal arch width, as you see, and arch length, as we studied through our charts. You see the IPR report, interproximal report, IPR report, the chart showing how much to strip from which tooth and which tooth to strip. Observe composite beads that have been placed for tooth movements on the lower canines. Composite beads for tooth movement. These are the sets of aligner trays, all neatly packed and sent back to the clinic. Then you start with 0-stage aligners for placing composite beads. Here's the patient with the aligners in place. I wonder whether you could appreciate this. You hardly see anything there, especially from around 3 feet or 4 feet distance. You really can't make out that the patient is wearing a factory of steel, like you usually see in a fixed appliance. Here, the pre and post comparison photographs which show space closure and improvement of smile. She's a confident lady now. Now let's go to another very interesting area of treatment, obstructive sleep apnea. We have obstructive sleep apnea clinic within our hospital, and it's been very active. I've dedicated one area for this treatment. The white area that you see here along the airway, that's actually the airway, the white area that shows the airway. This is normal upper airway in the first radiograph. Observe the narrowed airway. You'll find uvula narrowed airway in in a case of sleep apnea, patient with sleep apnea. This is how any normal person is. In awake position, you see how the airway is, and in sleep position, see how the airway is. It's closed a little. So that is a video of our private clinic Samadhan, and Nidra is our OSA center. Treatment of OSA with the customized digital mandibular advancement appliance. I'm showing you a case report once again. A 40-year-old male reported at our clinics. Patient reported with a complaint of snoring and intermittent breathlessness during sleep. On examination, he had incompetent lips with a backwardly placed mandible. These are pre-treatment photographs. Intraoral examination revealed a class 1 molar relation here. Overjet is normal, and so is the overbite. On cephalometric evaluation and polysomnography tests, it was diagnosed as obstructive sleep, clear picture of an obstructive sleep apnea. Prosomnus appliance was placed for the obstructive sleep apnea. That's the appliance that you see on the picture there. Following 1 year of prosomnous appliance, observe the mandibles come forward. Intraoral examination revealed that class 1 molar relation with normal overjet and overbite was maintained. There was no change in that. On comparison between pre and post treatment, lip competency was achieved. Pre and post steps comparison shows increase in the lower pharyngeal space. ESS score improved, and this lower pharyngeal space thereby reduced the reduced sleeping disturbances. Here you find the ESS score improved from 90 in pre-treatment, observe the red, to 4 in post-treatment. You can also see the change in the apnea hypopnea index from pre to post. This is the standard global score that's used for sleep apnea. Another case, 61-year-old male, pre-treatment and post-treatment, reported with snoring and disturbed sleep. Appliance was placed, prosomnous appliance. Comparison shows huge improvement in ESS score and apnea hypopnea index. The ESS score pre was 6, ESS score post was 9. AHI pre was 51.3 per hour, while AHI post was 32.9. Instructions to the patient. Patient is instructed on number of hours of wear to be worn day and night. That's very important. Appliance and teeth to be clean after every meal. Clean the appliance using detergent solution and brush. In case the appliance with screws, patients and parents should be given clear instructions on how to activate the appliance. Report immediately to the clinic in case the appliance is damaged. Of course, these are standard protocols. Not to leave it out of the mouth for too long. Now we come to the final frontiers, fixed orthodontic appliance. Well, most of the cases I'm going to show you are actual, case history so that it makes your sighting more interesting, and I hope you'll be able to remember more by seeing more pictures. So fixed appliances, those that, either by cementation or bonding, and they are etched teeth surfaces, as you all know. You know who that is. So there are a whole lot of, devices that we can use for fixed appliances. Now I'll show you, there'll be one more small video just to explain something to you all about. Now here I'll tell you a little about how tipping movement and bodily movement take place in fixed appliance therapy. Now we have two types of treatments. One is tipping movement that is done with the older techniques like pegs and tippage, while the newer techniques which use bodily movement is with pre-adjusted edgewise techniques. Now, the pre-adjusted edgewise technique uses lower forces. It uses lighter forces, while the peg and the tippage techniques, the older techniques, use heavier forces which cause tipping of the teeth. So with that, now as you all know, this is the crown. This is the root. This is the periodontal ligament, periodontal space. And of course, this is the alveolar Okay, the same here. Now, this is the force that is applied on a tooth by a fixed appliance. Here, force is used on the tooth by a fixed appliance. Now, what happens here is, let us assume that this is light force. Yeah? LF, we refer to it as LF, light force. While this is a technique which uses high force, as I told you earlier. Now, what is a high force techniques? As I said, the earlier techniques which are Higgs or tippage. Okay. While the lighter forces are the newer techniques, which is readjusted on the readjusted edgewise techniques. Okay. So what happens in when you have heavier forces used, like in the Higgs technique, you find that there is tipping of the tooth, which causes resorption of bone. You know. But also in this area, in the apex of the tooth, it causes resorption and causes tipping of the tooth because there is more heavy movement with the body. While against this, in the lighter forces that are used with the pre-adjusted edgewise, you find that there is resorption of bone. Beyond this aspect. So what happens here is there is deposition of bone over here as there is resorption happening in this area. Okay. So there's basically cell death that happens in the apical area, while there is cell action happening over here, along with resorption, cell death along with resorption, and there is deposition of bone in both cases. Now, why I have compared the techniques with the forces used and the resorption and deposition of bone is for you all to understand that when we use the Higgs technique or the tippage technique, we have three stages: stage 1, stage 2, and stage 3. So in Higgs technique, in stage 1, we basically do the decrowding and we start moving the teeth. That is basically because we are using heavy force in Higgs technique. You will have a tipping movement, as I explained. In stage 2, you continue the tipping movement, that is retraction of teeth. And in stage 3, since you have caused the tipping of the tooth, you need to basically give the root torque, that is, you're torquing the root, or you're uprighting the root with springs. That is done in stage 3. So this is about Higgs technique. That tipping movement is what causes cell death in the apical area. However, when you go to the pre-adjusted edgewise, you have again 3 stages. The first stage is leveling and alignment. The second one is the working stage. The working stage is actually flattening the teeth. While in the leveling and alignment, you're basically aligning the teeth, doing the decrowding and all that. You see? So in the working stage, you're doing the retraction. And finally, you're doing the finishing and detailing. That is to the final finesse of the case. Now here, as you see, because you're using a lighter force and you're using bodily movement, you find that the lateral bone absorption, bone deposition over here is an active cell life in the apex. So that was the mechanism of action. Forces are generated by the active components and transmitted to the tooth through the passive components to bring about tooth movement. Tipping movement is application of force to the crown of the tooth, generation of fulcrum within the root, which I just explained in the video. It's actually a fulcrum. Uprighting and torquing control movement of the apices of teeth. Uprighting in the mesiodistal movement. Torquing refers to the labiopalatal movement. Torquing refers to the labiopalatal movement, while uprighting is the mesiodistal movement. Please remember that. Now, this is bodily movement. Equal movement of the crown and the apex in the same direction. Force couple is applied to the crown. With rotation of the tooth, is correct positioning of attachment on rotated tooth, movement around the long axis of the tooth, apex the crown. Now, these are the stages in fixed appliance therapy. Leveling and alignment of teeth in stage 1. In stage 2, we have working stage overjet correction, overbite control. And stage 3, as you all know, is finishing and detailing. Leveling and alignment has got alignment of the arch, correction of crowding, crossbite, exposure, diastema, leveling and extrusion and intrusion. Working stage has correction of molar relationship using the intrachilastics, overbite control and overjet correction, curve of speed decreasing or correcting of the curve of speed, open bite correction, extraction spaces closure, and maintenance of a suitable arch form. In the finishing stage, we have alignment of individual teeth, root paddling, torquing of incisors, correction of midline discrepancies, final setting of teeth, and then, of course, debanding and debonding. Now, let's go back to some interesting clinical cases. This is a 21-year-old who reported to the department with a chief complaint of retroclined upper and lower incisors and a prominent chin. She had Buckley placed upper left canine and instanding upper left lateral incisor. She had a 4 millimeter gummy smile was seen, and in the post-treatment, please check for the improved smile post-treatment with the reduction of the gummy smile. And you see the alignment of teeth, I'm sure. Distant profile was seen in the pre-treatment because of a retroclined upper and lower incisors. Chin was looking prominent because of retroclined incisors. Please observe the change in profile after the proclination of the incisors. Proclination of incisors resulted in a straight profile post-treatment, well improving facial aesthetics. Treatment was started here with Damon-Q clear brackets 022 slot with an initial 013 copper nitride wire. Damon-Q is the best treatment option for this case as we required proclination and lateral expansion at the same time. Lateral expansion and proclination was achieved by combination of copper nitide and diamond Q brackets, which helped in relieving the crowding. See the well-aligned arches post-treatment. This is pre and that's post. This is a 19-year-old girl who reported with a chief complaint of irregularly placed teeth, instanding lateral incisors just like the one previous, with 3 millimeters of lip incompetency. The other one was about 4 millimeters. Look at her profile. There was severe crowding in the upper and lower incisors, as you can see, with highly placed canines and instanding upper laterals. Post-treatment, observed crowding was completely relieved. Canines were aligned, resulting in a nice, beautiful smile. There was an average growth pattern. Growth pattern remains the same, 3 millimeters of lip incompetency, competent lips, post-treatment. Pre and post. See the difference. Another one. The case was started with tippage plus mechanics 022-028. Extraction of all 4 first premolars was done, all 4s. There was a missing upper left second molar. Stage 1 was with the 016 AJ Wilcock SS wire and with class 2 elastics. Round nitide was engaged from stage 1 in the inner slot, right from the stage 1 as a modification, which resulted in quicker decrowding. You see? End of stage 1, we found a leveled upper and lower incisors. Total treatment time was about 6 months. Pre-stage 2, all 4 second premolars were bonded and aligned. Second premolars. Remember, the first premolars were extracted. Stage 2, class 1 elastics were used in all the 4 quadrants for first molar hook to cuspid circles for retraction. At the end of stage 2, all spaces were closed. Class 1 molar relation on both sides was achieved and well-aligned arches were seen. Stage 3, for tip and torque correction, 014 nitide wire was used in the under slot and 2128 SS main arch wire was used. There's no need of sidewinder springs in tip edge plus mechanics. The work of the sidewinder can be carried out by the underarch round nitide, since it's a double wire. Total treatment time was 16 months. Post-treatment arches, observe the well-aligned arches, upper and lower. Now we'll show you another case. This was a 23-year-old who reported with a chief complaint of retroclined upper centrals and proclined upper laterals with an impacted lower left canine. Pre-treatment, 2 millimeters of lip incompetency was seen, corrected during post-treatment. Post-treatment nasolabial angle decreased because of proclined incisors. The proclined incisors, observe the nasolabial angle. When smiling, we can see clearly that the retroclined upper central incisors and proclined upper lateral incisors. See the change in smile post-treatment following proclination of the upper centrals. Check for the fullness of the lips post-treatment. This case was started with MBT ceramic brackets, 022 slot. It was decided to start treatment only in the upper arch with 014 copper nitide for proclination and intrusion of the uppers. Low arch was bonded after 4 months following proclination of the incisors, of the upper incisors. Lower left lateral was extracted due to poor periodontal support to facilitate eruption of the impacted canine. There was no space for that. Lower left lateral incisor showed resorption of root due to pressure from the impacted canine. So we thought that was the best thing to do. An ANS implant was used to achieve absolute intrusion of the upper anteriors. In this case, observe the implants, the ANS implants above the root area, root apex of the upper anteriors. Lower canine was disimpacted with 014 night eye. Piggyback following soft tissue exposure by laser. Post-treatment class 1 molar relation was maintained. No changes. Impacted lower canine was aligned, you can observe. Upper incisors were proclined and intruded, as you can see. Observe the post-treatment, the pre-treatment photographs. Okay. So now, these are just a quick one on the components that we use, or the auxiliaries that we use. Elastics, separators, power chains, ligature wires, springs, hooks, extraoral appliances. All the necessary paraphernalia that we have to use with fixed appliance treatment. Passive components are, of course, the brackets, the bands, the buccal tubes, the lingual attachments, the lock pins, the ligature wires. Passive. Active components, which actually move the teeth. The word explains it all. Arch wires, springs, ligatures and elastomerics, elastics, separators and power chains. They actually move the teeth. For undergraduates here who are listening. So we have active and passive components, you see, in fixed appliances. What are the bracket materials used? Metals like stainless steel, gold, titanium, nickel, chrome cobalt, plastics. Ceramics are used like laminated, zirconia-based and polycrystallines. There are combinations of metal reinforced ceramics and metal reinforced plastics. Magnetic brackets are also available with various combinations of chromium, cobalt, and iron. These are the brackets and the wires and how they look. Brackets, ligation of brackets are conventional ligation and self-ligating. With edgewise and Beck brackets, we use conventional ligation, while with the speed brackets, we use self-ligating. Here, this shows you a passive and an active. Observe the slot depths between the passive and the active. Now let's go to some digital design and appliances for treatment systems. Digital design and customized appliances treatment systems. You can also make custom brackets, that is, depending on the anatomy of each tooth. You have custom labial brackets, which are CAD-CAM, used with CAD-CAM technology. You have brackets that are contoured to a particular place on the surface of a particular tooth, depending on thickness, depending on the arch wire size, depending on your treatment time. So these are custom brackets. This is basically a CAD-CAM steps of customized bracket construction, making. So you use a light-based imaging device. You get a treatment plan on your computer. You obtain a virtual model like that. The selection of wire and sequence and progression is done with virtual bracket placement. Wire bending is done robotically, producing arch wires. So an orthodontist's job becomes very easy. So now we go on to lingual appliances. Which is the most invisible appliance? A lingual appliance. It's not a ceramic bracket. It's not an aesthetic bracket. It's a lingual bracket. So here you have Incognito by 3M and Lingual Matrix. You see all the brackets are placed on the lingual surface. You don't see anything on the facial, labial, buccal surface. Here's a case of a 19-year-old female, a 20-year-old female, sorry, who reported with the chief complaint of forwardly placed front teeth, incorporated lips, and acute nasolabial angle. Intraoral examination revealed a class 1 molar relation, you can see, with bimax, a perfect bimax protrusion. Arches were well aligned though. Customized lingual brackets, which I just showed you the construction of a customized bracket. So we use customized lingual brackets following extraction of all first premolars, all fours, and an 013 wire was placed. Retraction started for closure of spaces on 17x25 TMA arch wire. Post-treatment extraoral photographs. Confident girl now. Comparison of pre and post shows competent lips, reduced proclination, and a confident individual. Now let's go on to labial appliances, facial appliances. The system allows us to use 3D, specialized braces, specifically take your unique anatomy into account. That's of course for all, customized. Braces are custom fitted on your teeth. Allows advanced orthodontics to calculate the most optimal orthodontic plan for you. So you know everything before you start. This is the beauty of artificial intelligence and robotics being used in dentistry and orthodontics. So it's a highly customized prescription, as said. There's a bracket for each tooth, custom made. See, the traditional approach, I truly agree, in the 70s and 80s was one size fits all, versus the present approach, which is millions of treatment options for every tooth. So look where orthodontics has gone. There was a one size fits all. It was like the old boarding schools where you got your uniforms passed down from one class to the other. And here now, today's options are so great. You get a million options for one tooth. Amazing. So here we have a 20-year-old who reported with a complaint of forwardly placed teeth. Intraoral examination showed a class 1 molar relationship with proclined upper and lower anteriors and a typical trauma from occlusion. It was decided to give customized labial appliances. Insignia following 4 first premolar extractions was decided on. That's the chart. Following extraction of premolars and banding, intraoral. That's his profile. Extraoral. Treatment was started on the first appointment with upper and lower 14x25 TMA arch wires. Preformed and custom material stainless steel. So this is right. Okay. And so this is how it happened. This is the case. It's on now. Right. So preformed and custom materials, stainless steel and nickel titanium, gold, alpha beta titanium. These are all the types of arch wires that we have. We have posted and non-posted arch forms. We have shapes like round, square, and rectangular, depending on arch forms. We have functions which can be active or it can be passive. These are the types of arch wires. These are all elastomerics. Latest elastics are used. Normal forces are used from 150 to 300 grams. These are the uses of the elastomerics. They help in separating, they help in closure of spaces, like power chains. Ligate elastics are used. It helps in treatment of crossbite, correction of intra-arch relations, derotation of teeth. Look at these are the types of elastomerics that we have. So these are basically the different types of components, like what do we have in orthodontics for the undergraduate students who are not orthodontists and who are listening to us. We have metal and we have rubber. There's a lot of it. But of course, now we've gone on to composites and plastics and invisible aligners. These are springs that are used, different types of springs, uprighting springs and begs, rotation springs, torquing springs, and of course, coil springs, which I showed you, open and close coil springs. Well, these are instructions to patients who usually come to the dental clinics. Brush your teeth before and after every meal and before bed. Avoid eating hard and sticky foods because it could break your brackets. Contact the orthodontist in case of pain or a loose appliance, and go for your routine dental visits. Those are the do's and those are the don'ts. Complications in orthodontics, periodontal problems after 3-4 years, demineralization of teeth and sensitivity, mobility of teeth, pain, tooth resorption, and loss of tooth vitality. So these are, like any other treatment, can have complications. These are the orthodontic complications. So any orthodontist must take care and be careful while using force. The basic point is force, the use of force and the use of not allowing demineralization to occur and creating sensitivity by removing valuable enamel. Well, this is just a small video on all the types of procedures that happen. It's just a comprehensive video, which I found quite interesting, which shows you everything, right from deciduous teeth coming in to malocclusions that happen, and how the orthodontic treatment is done for malocclusions. See, that's the elastics and the brackets and the wires. So that's the metal and the elastic, undergraduates. Very artful, don't you think? Well, with this session of what I've just said, the advice that I'd have for undergraduates who are here to take up orthodontics. And it's a very interesting field. And for orthodontic PG postgraduate students and newcomers into the field, continuing education is the key. Do not forget and do not think that we know everything. There's always more to learn. Orthodontics is a field that's always moving forward with new techniques and new ways of treating. So keep your eyes and your ears open and be ready for change. Because the changes that have happened are phenomenal, let me tell you. In the 80s, when we did our masters, to now, I find the changes are amazing, just like the rest of dentistry. So with this, I come to a few quickly come to some upcoming international events. With your permission, sir, Professor Ibrahim. Okay. We have the India International Orthodontic Symposium, the IIOS, which is coming up very soon. We'll be conducting the first Indo-European Orthodontic Conference in Coog under the aegis of the Eurasian Orthodontic Society and the Indian Orthodontic Society. This conference will take place from the 3rd to the 7th of April of 2023 in Coog. All of you are invited. We'll be happy to have you. Yes. Yes. As a major stride towards digital India, the government of India, under the leadership of our Prime Minister Narendra Modi, has initiated the process of creating a digital health ecosystem. Coog will be the first institute to implement this electronic health records under SIDMET, machine learning and artificial intelligence-based analytics. We are proud and happy, and we'll be very happy to have you with us. This is our Department of Orthodontics, which Professor Ibrahim and a lot of people from the ICD have visited. We look forward to having all of you as our guests any time of the year. Thank you.
Hey, thank you very much, Professor Sunil. for the interesting presentation and also the introduction of the conference that you're going to host next year. So we have also with us the professional. We have our three strong person in ICD here to join us. One called the President, Dr. Hao Kim Chuan, the Vice President, Professor Arshad Malik, and also the Registrar, Dr. John Ling, who also has joined to listen to your talk. Okay, before we go, there is one question from the chat. This question from Tan Chan To. He asked, dear doctor, how old can we start to treat with twin block for appliance for both gender? And any limited age, and how long for this treatment?
Between 5 and 14 years.
5 to 14 years. Okay. And how long? How long the treatment takes?
Well, about a year.
Okay. All right. So
about a year maximum.
All right. I hope that answers the question. And now maybe our president orthodontist and also our registrar is also orthodontist want to ask anything to Professor Dr. Sunil or even Professor Arshad Malik, our vice president, who all-rounder, he can,
Thank you. My president is there. It is not ethical that I can comment before my president. So it is over to Dr. Hao. After Dr. Hao, I will say something.
Thank you, Professor Ibrahim, Vice President, Professor Arshad Malik, and of course, our Professor Speaker, Professor Sunil. But I'm very impressed by your dental school, which is magnificent, and you seem to be at the top of the hill. And likewise, your orthodontic and your technology also on top of the hill, just like your dental school. All right. So you have presented a very impressive presentation from removable appliance all the way to digital orthodontic and AI initiated orthodontics also. So, and you treat a wide variety of cases, and you have just shown us how orthodontic can be nowadays. That now one question for you is that what do you think about the digital orthodontics? Do you think that we are actually able to treat more complex cases in such a way that we are able to reduce the number of orthodontic surgery in some complex malocclusion? All right, Professor, for your comment.
I think very positively on that, and I think a lot of these surgeries can be reduced with digital orthodontics and the technology that is coming in. I think very positively on that, Professor.
Okay, very good. And what do you think about the age of treating a patient? Should we start as early as possible, let's say in a class 3 patient, or should we actually wait until the patient finishes the growth before we do an orthodontic surgery?
Well, the treatment should be started as early as possible from an orthodontic angle. If you are talking about because prevention is better than cure, if that's what the question is, Professor. Because interception, I mean, it's been an old theory that always intercept the problem. So interceptive orthodontics, and then going on preventive orthodontics, interceptive orthodontics, and then going in for actual treatment will reduce the treatment time for sure. So is that the question, Professor?
Yeah, but however, you can see that there are a large number of patients, including the dentist, especially the general dentist, feels that patient with skeletal class 3, they shall not be treating early. They usually advise the parents or the patients to wait until the growth completed and then to plan for orthodontic jaws. So what do you think about this statement? Do you think it still hold water nowadays?
See, I believe that growth modification can be done to avoid surgery.
Mhm.
With simple devices like activators and bionators, we have seen phenomenal changes where people felt that a retrognathic mandible could not be corrected or a prognathic mandible could not be corrected, and we had to go in for surgery. Starting early, even with things like face masks, it's given us phenomenal results. So I do believe that if a parent can bring in a patient early to the orthodontic clinics, and with today's cephalometric analysis and the computer generated images that we can get, it's very easy to avoid surgery. So I do believe that growth modification and early treatment could avoid actual orthognathic surgeries from happening in most cases.
Thank you very much. Okay, I have no further question. I shall ask my Vice President, Professor Ashad, to continue.
Thank
Thank
you.
you, Datu. Actually, Datu Ho is our not only president, that he's an international speaker in orthodontics, and especially with reference to aligners, he's considered as authority.
I've heard a lot about him, and I'm
Yeah.
honored to have honored to have had a question from him.
सुनील वो उर्दू में कहते हैं कि यार मजा आ गया. You see, it's a so wonderful presentation that you see, Sunil, when we were in initial stages, when I was assistant professor, associate professor at that time, our every third or fourth list was orthognathic surgery. And
Yes.
you people, with the modification of the treatment, with early growth intervention and these modern devices, and the people like you, Sunil, Professor Howe, had really retarded of the work of maxillofacial surgeon. And you see, in hardly in 1 or 2 months, I used to get the orthognathic surgery now. It is so wonderful. My question just very simple. I used to have many interpretation nationally, internationally, regarding the use of soft lever laser to enhance the treatment of movement of the teeth. And there are so many publications nationally and internationally here in Pakistan as well, that we are using these soft lasers, and especially diode lasers, especially at the nanometer, 780 nanometer, and sometimes less, and giving jewels during the initial stage of movement of the teeth, and especially below 12 or in between 12 and 13 years. We get the more prompt result as compared to that of the patient not treated with the encourage of the soft laser. What is your opinion that if we add an extra therapy with reference to all these modalities, have you ever experienced, or what is your idea?
We are using lasers, and we use lasers very, with a lot of good results for pain reduction and for accelerating tooth movement, because obviously you are getting a softer bone, you are causing a certain amount of resorption. So the amount of actual tooth movement through pressure is being reduced because you're using a laser. So yes, we do. 660 nanometer to 810 nanometers is very good. It works very well.
And secondly, it is so lovely to see your clinic. It's so wonderful that I say that half of the disease is over. But just sitting in your clinic, so wonderful presentation, that it's a so lovely hilly area in front of your clinic. It's so beautiful clinic. Congratulations. Thank you very much.
Thank you, sir. Namaskar.
Okay, thank you, Professor Ashad Malik. Dr. John Ling, Registrar, you want to say anything, our speaker?
Hi, wonderful lectures. I'd like to ask a little bit about the artificial intelligence. What do you say the AI or AI robotics would help us in orthodontic treatment in the terms of, say, prognosis of treatment, as the amount, or the artificial intelligence can tell us which type of appliances is better to do certain jobs. Say aligners would be better for a case, or a fixed appliance would be better for a case, or is there a need for functional appliances or class 2 correctors like that is better, because it need quite a lot of data to generate the artificial intelligence to tell us what is best in our clinical scenarios.
Well, I think your question would best be answered, Professor, by saying that it also depends on what type of case you're treating and what type of diagnosis you do on the case. Because every case may not, there could be a case which is 90% corrected or 100% corrected by AI, but not every case could be corrected absolutely with AI. There could be cases like orthodontic cases which you are starting at a lower age group, let's say around during the early stages of growth modification, where you may not be able to use AI completely. But as you move forward and get onto aligners, with your diagnostic tools, it works very well. But better treatment planning, customizing for each patient, AI can tell whether extraction is needed or not needed. AI cannot be used for deciding which bracket is best to use or work in a particular situation. So I think AI has its limitations. We need to still grow with AI. I think a lot more data will help. And that is the reason why we have started an artificial intelligence mission at our school, which we hope will result in a lot more data, because we are treating about 650 to 700 orthodontic patients every 6 months, new patients coming in. So I'm hoping that in the next 3 to 4 years, we will be able to build up data with about 1,200 patients a year to build up our AI base, because all AI treatment planning is going to depend on the amount of data that you have available to create millions of treatment plans.
Sure. So do you think at this, we are actually still quite early stage in the AI technology?
Very true, very true. We are in our infancy.
Yeah, because I'm involved in a company doing a bit of AI as well. We are planning tooth movements, both aligners and fixed appliance, and actually doing printing of the brackets.
Very interesting.
It's not unlike Insignia. Actually, they give you a stock bracket, and they just basically they tell you it's AI, but the bracket is not that custom made. Because if you ask detail enough, they would actually give you a high torque, low torque, and then just change the base. They actually not print it for you.
Yes.
Because at the moment there is still a problem with printing the metal. Because that is a very difficult thing to do at this moment in time. Because it's the accuracy of the slots is not very good at the moment.
Exactly.
The plastics are better, the aligners are better.
Yes.
So I think there's still a lot of scope for developments in this case. And I'm glad that they are not only companies doing it, institutions are doing it as well. Because I teach at the University of Hong Kong. They are not really doing this sort of stuff, right? Because it needs quite a lot of government supporting the money.
Yes.
Right. You either have the money coming from the industry.
Yes.
Or you get the money from your academics, right? Yes. If you are academic, then you work. It's part of your job to do things like this. But if you are working as a company, you need a lot of revenue to buy instruments, computers, and also IT staff.
Very
There are a
true.
lot of IT staff to work out all these logistics and how the AI work, and then working all the way, getting your big data,
Very true. Very true.
feeding all the information. The clinician, we can get the data,
Yes.
right? Raw data,
Yes.
and feed it to the machine.
Yes.
But we still need the technicians and the AI people to work for us. We actually don't have very little idea how it works.
I agree with you on this, because
Yeah.
permutations and combinations are so large and so big and so huge.
Yeah.
And that's the reason why I said that I'm very confident with aligners with AI, but I'm not that confident with brackets, because it's not yet reached its pinnacle. We are in a very infant stage with brackets, as you said, which you very rightly said. There's a lot of work in progress and a lot more to be done with customized brackets. Yes, I do agree with you.
Okay, thank you very much. Very interesting discussion we have tonight, Professor Sunil, of course, with Dr. Hao Kim Chun, our renowned orthodontist, our president, of course, John Lings, also an orthodontist, of course, with Professor Samadik. And we hope that those who attend our tonight's webinar will have fruitful information for them. And again, on behalf of Section 15, I would like to thank you, Professor Sunil, for sharing your knowledge with us, with our participants, with also our members tonight. Thank you very much.
Thank you very much, Professor. And thank you so much, Professor Hao, Professor Ling, and Professor Malik. It was so nice to have all of you here. And thank you for listening to my presentation. And thank you, Professor Ibrahim. And I do look forward to having all of you here in India. Professor Ibrahim is a dear friend. So Prof, probably please take this as a personal invitation to bring all of them here to Coog, India, as my personal guest. You can stay on my coffee plantation. I have nice guest house there. Yeah. And we look after you very well. So I look forward to having you.
Thank you very much, Professor Sunil. Of course, we look forward to visit your school. Okay.
Excuse me, Professor Ibrahim, Sunil. There will be big problem for me to visit you. Especially, I will refer it as a visa problem for Pakistan.
No, I'll get you the visa. Don't worry, Prof.
Because these days I am suffering from getting visa for Bangladesh, and daily I have to go to embassy, and there's much difficulties I am facing. But for India, if you will help us, inshallah, we will do visit, inshallah.
I'm there, inshallah. I'm there with you. I look forward to having you, Professor Malik.
Okay. All right. As usual, I will introduce our next speaker in 2 weeks' time. He's Professor Dr. Adam Hussain. He will talk on maxillofacial orthodontics, hope and challenges. Professor Adam is at the University of Sharjah, although he's a Malaysian actually, working in Sharjah for 2 years. And he will be sharing with us on maxillofacial orthodontics and hope and challenges. So please do join us in 2 weeks' time on the 8th of June to listen to Professor Adam's webinar. Thank you very much. I think it's a bit late now. In Malaysia, it's almost 11, now 11 past. So we'll see you all in 2 weeks' time. And good night, Professor Sunil, our speaker, and Dr. Hao, Professor Arshad, Dr. John Ling, and all our participants. Of course, my committee member, Datin Mayuna, which in the meeting tonight. So hope to see you all again in 2 weeks' time. Thank you and good night.
Good night.
Bye.